Hi, my name is Sarah Erpelding, and for my topic over the voiced over PowerPoint, I chose to do catheter-associated urinary tract infections, or Cauti for short. We will first talk about what is a Cauti and why is it important to us as nurses. As nurses, we are devoted to our patients' safety and not to cause them harm. Cautis can lead to longer hospital stays and potentially life-threatening infections for our patient. A Foley catheter is a catheter that is inserted into the urethra to help drain urine. Infections happen when sterile technique is broken and when catheter care is not done properly and/or frequently enough. Some symptoms of a Cauti include cloudy or bloody urine, strong urine odor, chills and fever, fatigue, vomiting, and signs of sepsis, including tachycardia, tachypnea, and hypotension or low blood pressure. Cautis can be diagnosed by urine analysis. Catheter-associated urinary tract infection rates are as follows. More than 1,300 deaths each year are associated with UTIs. Over 93,300 Cautis each year in the hospital setting. For each day that an indwelling urinary catheter remains in place, a patient has a 3 to 7% increased risk of acquiring a catheter-associated urinary tract infection. In a case study done by A. Ferguson in 2 units of the adult inpatient care setting, one was on the telemetry unit, the other was in a neurotrauma ICU. The telemetry unit had 7.49 Cautis per 1,000 catheter days. The neurotrauma ICU had 4.12 Cautis per 1,000 catheter days. The nurses from both of these units were asked to fill out a survey of how much they knew about properly inserting and managing a Foley catheter. After the survey was completed, the nurses were required to attend a mandatory class about how to properly insert and manage a Foley catheter. After the class, the Cauti rates decreased on the telemetry unit to 0 out of 1,000 catheter days and 1.56 out of 1,000 catheter days on the neurotrauma ICU unit. There are many different reasons that we decide to insert a Foley catheter into our patients. Some of these reasons include acute urinary retention or obstruction, accurate measurement of urine output in critically ill patients, which is most often seen in the intensive care units, perioperative use in selected surgeries, assistance in wound healing, which can be seen throughout the hospital and in long-term care facilities, hospice or comfort care, which can be seen in hospitals and in long-term care facilities, and required immobilization for trauma or surgery. Prevention of catheter-associated urinary tract infections. We can use the nomogram No Cauti to help us prevent urinary tract infections that are catheter-associated. N stands for need for a catheter assessed. We need to assess and see if a catheter is necessary for our patients. We need to O, obtain patient consent and offer the patient education. We need to have C, which is competency. Clinicians who insert Foley catheters must have documented competency of catheter insertion and management. We need to maintain asepsis during insertion and while the catheter is in place. We need to have unobstructed flow in the catheter tubing, which means no kinks, and the catheter tubing is in a downhill motion to the catheter urinary drainage bag. T, timely catheter removal. I, infection risk. We need to collect a urine specimen only when an infection is thought to be found. Prevention continued. We can do self-check surveys on our units to see how much we know about inserting a Foley catheter and managing a Foley catheter. There are DVD and PowerPoints on proper insertion and management. We can do handoff clinical checkoffs for insertion. We can do clinical compliance checks randomly across the unit and across the hospital. And we can provide education on proper catheter care and frequency of catheter care. What we can do as nurses. We can question Foley catheter care orders from the physician to make sure a catheter is warranted in our patient. We can have a second nurse present on insertion. We can maintain sterile technique during insertion, and if at any time sterile technique is broken, start the procedure over again. We can provide catheter care frequently and make sure we are up to date on how to do catheter care. And we can always discuss catheter care removal with our physicians and the patient care team. If we follow these simple rules, we can help to prevent Cautis in our patients.